In this lecture, we're going to talk about malabsorptive syndromes. We're going to start off with the framework and then move into the individual diseases. Let's start off with that framework first. When you ingest something, it enters the esophagus, goes into the stomach. And in the stomach, it gets churned, mixed with acid, until eventually it is secreted to the pylorus into the duodenum. There, the pancreas secretes enzymes in the duodenum, as does the liver and gallbladder secrete bile acids. These mix with that acid and food contents, start to get broken down, and then the absorption begins almost immediately. In the duodenum, the minerals you're going to absorb are the thick minerals. That is folate, iron, and calcium. So disorders of the duodenum are going to lead to anemia, macrocytic for folate, microcytic for iron, and calcium absorption will lead to osteoporosis. Here also are where carbohydrates are absorbed. And the deficiency of the ability to absorb carbohydrates generally does not present with weight loss. What you expect to see in carbohydrate malabsorption is bloating, belching, foul-smelling, flatulence, and diarrhea, but no weight loss. Then the intestine kind of does its thing all in between, and there's a lot of absorptive area there, so it's not really focused on any one thing. And then we have the terminal ileum. And the terminal ileum is where those bile salts are reabsorbed along with B12. Now, bile salts absorb fats, and without the ability to absorb fats or bile salts, you lose the fat-soluble vitamins, A, D, E, and K. You just have to know them, A, D, E, and K. A, D, E, and K, fat-soluble vitamins, A, D, E, and K, and the deficiencies that go along with them. Vitamin A deficiency will lead to night blindness. Vitamin D deficiency will lead to osteoporosis. Vitamin E deficiency will lead to nystagmus. And vitamin K deficiency will result in bleeding. The colon is there to absorb water and generally does not have too many things associated with it. The pancreas is designed for protein digestion so that complex proteins can be broken down and absorbed. If you don't have a pancreas, you can't break down proteins. Protein malabsorption results in the symptoms associated with a low albumin state. It's going to be lower leg edema, ascites, or anasarca. Fats are what we're going to talk mostly about. And fats, you're going to have steatorrhea. If you cannot break down or absorb fats, fats are going to stay in the intestinal lumen. And you have to decide, is it a product of this system or is it a product of the intestinal border itself? So someone comes in with signs and symptoms of malabsorption. The first thing you do is give them a 100-gram fat diet and then collect their stool over 72 hours. What you're trying to decide is, do they really have malabsorption? Because if they have less than 14 grams per day in their stool, they have no malabsorption. It's something else. But for the sake of argument, let's say that they do have more than 14 grams per day of fat in their stool, and now we know they have confirmed malabsorption. The next step is to decide, is the intestinal luminal border intact, or is it a problem with enzymes? The idea is, if you give someone a compound that is already digested, that requires just an intact epithelium and nothing else to be absorbed, if it gets absorbed, the intestinal luminal border is intact. If it doesn't, then it's the intestinal luminal border that's to blame. We do that with D-xylose. If D-xylose is absorbed, the intestinal luminal border is intact, and it's probably a problem with the pancreas. If you're deficient in pancreatic enzymes or the duct leading to the duodenum is blocked, you simply have to replace what they don't have. This happens in patients with chronic pancreatitis and cystic fibrosis. If it's not absorbed, it's an intestinal luminal border. And the next step is endoscopy with biopsy. And most of the time, you are not going to follow this pathway. You're not going to do the fecal fat assessment. You're not even going to do D-xylose. You're going to listen to the vignette or listen to the patient in front of you, and you're going to figure out what it is based on their history. If someone has cystic fibrosis and you know it affects the pancreas, you don't have to do a D-xylose absorption test. You can just give them the pancreatic enzyme. If someone sounds like they have celiac sprue, which we're about to talk about, you're going to diagnose celiac sprue, not test their fat. This is the academic exercise you'll see, but very rarely do you actually do this. So let's talk about the individual malabsorptive syndromes that you should know about so you can recognize them. The first one is going to be celiac sprue. This is a gluten allergy. And it's an autoimmune disease, primarily IgA mediated. The patient is going to present with diarrhea, bloating, and weight loss. There is a skin manifestation of celiac disease, and if you have it, then you have celiac disease. If you don't have it, you could still have celiac disease, and that is dermatitis herpetiformis. All patients with dermatitis herpetiformis have celiac sprue, but not all patients with celiac sprue have dermatitis herpetiformis. If you suspect celiac sprue, and it's very hot right now, so if you see a question about celiac sprue, it's probably the answer. If you suspect celiac sprue, it begins with the antibodies. And the best to get is a TTG. Do not get gliadin. And you may be asked to choose between tissue transglutaminase, the TTG, and endomyocele. In real life, if either are positive, you go to the next step because the person probably has sprue. But if you're asked which one do you pick, TTG. Even if the antibodies are negative, if you have a high suspicion of celiac sprue, you're going to get the EGD with biopsy. This is going to show blunting of the villi. And that's what causes the problem. Loss of surface area. You normally have microvilli, which maximizes absorptive surface. In this disease, the villi are blunting, you lose that surface area and you can't absorb as well. This is going to affect mostly the proximal duodenum. So it wouldn't be surprising to also find that these patients have iron deficiency as well as osteoporosis. So keep an eye out for iron deficiency and osteoporosis. The treatment of celiac sprue is to avoid gluten. This is easier said than done since so many products have gluten in them, and it takes 3 to 4 months of gluten avoidance in order to work. So a diagnostic step is not to have them change their diet. They will not get better with avoidance of gluten because they can't do it for the length of time that they need to do it for. In comparison, if someone has lactose intolerance and we need lactase to digest mom's milk, but as we age, we don't really need it anymore, so if you don't use it, you lose it. Lactose intolerance is seen as people get older and is a higher incidence in Asians. The patient is going to present with that carbohydrate malabsorption. Bloating, foul smelling, flatulence, diarrhea, but no weight loss. And the diagnosis is made simply by avoiding dairy. And within a day of avoiding the dairy, they get better. Or you could just do a trial of empiric lactase enzymes. And so the person then knows if they don't want those symptoms, they either avoid dairy or they take a lactase. Tropical sprue is something you have to know about. And the reason you have to know about it is because it looks just like celiac sprue. It is caused by an infection, and it is not an autoimmune disease. The patient is going to present with celiac sprue. Exact same presentation. The diagnosis is going to be made on endoscopy with biopsy, and it's going to show sprue. But this person's going to be a Caribbean farmer. And he's not going to get better with avoidance of gluten, and so you treat with antibiotics. I teach it to you only because it has the same word in it as celiac sprue, tropical sprue, and it looks just like it. So you might be tricked into thinking that this might be the right answer if you didn't know about it. So this is more of one you should avoid. Usually it's celiac sprue. And the last one is Whipple's disease. Infection with T. whippleii. The patient presents with malabsorption plus brain, plus joint, plus lymph. Brain, joints, and lymph nodes are involved in Treponema whippleii disease, Whipple's disease. The diagnosis is going to be made on EGD with biopsy. And either you're going to see PAS positive macrophages on light microscopy or the organisms on electron microscopy. Let me tell you what this means. You're going to have to take a look at a picture, right? So it's going to be a malabsorption question. They're going to show you a picture. If they show you the epithelium with lost villi, celiac sprue. If it looks normal, celiac sprue. If they show you a light microscopy images with little pink stuff all over the place, like little dots and punctate, Whipple's disease. If it's a question about malabsorption and they show you an electron microscope, Whipple's disease. Treatment for Whipple's disease is with either trimethoprim sulfa or doxycycline. Okay, these 4 diseases you have to know, but if you're going to study any of them, it's going to be celiac sprue. Know that this process exists, but you are very rarely ever going to do it. It's more important to know the diagnostic workup for celiac sprue than anything else. But then be able to identify the different types of syndromes you have from loss of fats, protein, carbs, or certain vitamins, and be able to isolate where you might have a problem with absorption based on the disease they have and where these things are absorbed from. That's malabsorption.